CV benefits is now becoming part of that P&T discussion. So when we're doing a clinical evaluation of a new diabetic therapies, we are including that CV benefit as an actual section in our profile. What we look for in a CV benefit is obviously relative risk reduction. But when we look at it, we look at both the composite of a MACE endpoint, but we also want to know exactly where those reductions are. Is it mortality? Is it hospitalizations? Is it stroke? So we are looking at the specific endpoint, both a composite, but we're also looking at the individual components. Now, there's been a couple products that have shown CV benefits. The question is whether or not those products or that benefit is specific to those products within that category or that MOA, or is it a class effect? And that's something right now we're sort of taking a wait and see approach. Is one SGLT2 going to have similar CV benefits as another? Is one GLP-1 going to have similar CV benefits as another GLP-1? So that's part of the discussion now is, do we think it's going to be an individualized benefit, or do we think it's going to be a class effect? We appreciate that now we are getting CV benefit data from these products after so many years, because we do know that obviously diabetes results in cardiovascular complications, and we've always been taught that an A1C reduction of 1% always led to a 10% reduction in events. Now we're getting the data to actually support that. And this helps us too, because we also get pharmacoeconomic models from manufacturers in diabetes that were traditionally based on assumptions, but now these models can actually be based on actual clinical data and actual outcomes data to show a reduction in events could potentially lead to reduction in cost because of the lower hospitalizations and lower healthcare resource utilization. We don't know how much it's impacted physicians yet in terms of therapeutic choice for their patients. Now, as more data comes out, then yes, there is a potential that this could be used earlier on. Because of the CV benefits, it's more potential that it could be used for a larger portion of the population, more than just the ones that are quote unquote at risk. But I think it's too early to tell specifically, because we haven't really seen a shift in prescribing patterns. We haven't seen an increase in, say, market share for one particular product because of that CV data. So what again, it's a wait and see approach, because the data is relatively new. We just don't know how much of an impact this is going to have in a real world setting.